Hello friends, welcome to my channel Pediatrics and Life Tips. Today I will talk about celiac disease, which is also known as gluten-dependent enteropathy in children. In this video I will discuss the causes, pathophysiology, types and symptoms, and complications of celiac disease. First I will define celiac disease. It is an immune-mediated systemic disorder triggered by gluten and its related prolamins in genetically susceptible individual. The immunologically mediated inflammatory response primarily affects the mucosa of the small intestine, where it progressively leads to the flattening of mucosa, resulting in maldigestion and malabsorption. Now, its prevalence is about 1.4% on the basis of serology and is 0.7% on the basis of biopsy finding. It is common in European countries, especially in Ireland and Finland, and also in North America and Australia. The incidence is increasing in Africa, Asia, and Middle East. Celiac disease can occur at any stage of life. Classic disease appears in children aged 9 to 18 months, but it may also occur in adults, and the female sex is more affected. Celiac disease has a strong hereditary component. There is an association between celiac disease and two human leukocyte antigen haplotypes, which are DQ2 and DQ8. Such haplotypes are expressed on the antigen-presenting cells of the mucosa of the small intestine. 90% of the patient express DQ2 heterodimer, while 7% express DQ8. Now, the prevalence of celiac disease in the first degree relative is approximately 10%, and the concordance in the monozygotic twin is about 100%. Now, its pathogenesis. The intestinal damage results from cell-mediated and humoral-mediated immune response to the gliadin, which is a component of gluten. Endogenous tissue transglutaminase deamidates gliadin into a negatively charged protein and thus increases its immunogenicity. Now, the autoantibodies to type 2 transglutaminase is the hallmark of the celiac disease. There is also raised level of immunoglobulin A as a result of mucosal stimulation in celiac disease. The classic celiac lesion occur in proximal small intestine with typical histological changes of villus atrophy, crypt hyperplasia, and increased intraepithelial lymphocytosis. Now, I will discuss the clinical features. There are 5 possible clinical presentations of celiac disease. First one is the typical or the classic celiac disease. It appears in children aged 9 to 24 months after introduction of foods that contain gluten. It is characterized by gastrointestinal signs and symptoms such as chronic or recurrent diarrhea, vomiting, abdominal distension, abdominal pain, anorexia, weight loss, failure to thrive, muscle wasting, irritability, apathy. In this case, the stools may be bulky, pale, frothy, greasy, and foul-smelling. Occasionally, there may be constipation, rectal prolapse, or intussusception. Rarely, celiac crises can occur, and in this there is explosive watery diarrhea, marked abdominal distension, dehydration, hypotension, and lethargy. There is profound electrolyte disturbance, including severe hypokalemia and metabolic acidosis. In typical celiac disease, celiac serology and the pathological findings on mucosal biopsy are positive. Second type of presentation is the atypical celiac disease. This occurs in older children and young adults. Gastrointestinal signs and symptoms are minimal or absent, while various extraintestinal manifestations they are more common. Iron deficiency anemia, which is resistant to oral iron supplements, is the most common, while anemia due to folate, vitamin B12 deficiency, and anemia of chronic disease may also occur. Other extraintestinal manifestations of atypical celiac disease include rickets, osteoporosis, dental enamel hypoplasia, aphthous stomatitis, short stature, dermatitis herpetiformis. It is a pruritic papulovesicular skin lesion involving the extensor surfaces of the limbs, trunk, buttocks, scalp, and neck. There may also be erythema nodosum. In atypical celiac disease, there may be peripheral neuropathy, epilepsy with bilateral occipital calcification, cerebellar ataxia, delayed puberty, secondary hyperparathyroidism, alopecia areata, idiopathic pulmonary hemosiderosis, cardiomyopathy, or arthralgia and arthritis. There may be isolated hypertransaminemia. Now, in atypical celiac disease, the celiac serology, that is anti-tissue transglutaminase and endomysial antibodies, are positive, and the mucosal pathology on endoscopy and biopsy is also positive. The third type of clinical presentation is the silent celiac disease. This occurs in older children and young adults. In this, there are no apparent symptoms, but the pathology and the serology both are positive. The fourth type of presentation is the potential celiac disease, which can occur at any age. In this, the child may or may not be symptomatic, and the symptoms may be gastrointestinal or extraintestinal. In this, serology is positive, but the mucosal pathology is normal. These individuals have genetic compatibility with celiac disease, and full-blown disease may develop at a later stage of life. Now, the fifth type of clinical presentation is the latent celiac disease. It occurs in older children and young adults. The individuals have previous or future gluten-dependent enteropathy at some point in their life. The serology may be positive or negative, but the pathology is almost normal. This is the celiac iceberg. Above the surface is the symptomatic celiac disease, which include the typical and atypical forms. Then lower down is the silent celiac disease, and in the bottom is the latent celiac disease. Now, certain genetic syndromes are associated with celiac disease, and these include Down syndrome, Williams syndrome, and Turner syndrome. Certain autoimmune conditions are also associated with celiac disease. These include type 1 diabetes, autoimmune thyroiditis, autoimmune hepatitis, and autoimmune cholangitis. Primary biliary cirrhosis or Addison disease, Sjogren's syndrome, and selective immunoglobulin A deficiency may also occur in celiac disease. These associations of genetic syndrome and autoimmune disorders with celiac disease is due to sharing of the identical HLA haplotypes. Once these diseases are established, they are not influenced by a gluten-free diet. Now, complications of celiac disease in a non-compliant patient. These include osteopenia, osteoporosis, anemia, non-Hodgkin lymphoma, ulcerative jejunopelvitis, enteropathy-associated T-cell lymphoma, refractory celiac disease, and recurrent abortions. Now, the differential diagnosis of celiac disease in a child include autoimmune enteropathy, cystic fibrosis, inflammatory bowel disease, irritable bowel syndrome, cow's milk, soybean, or egg protein intolerance. Thanks for watching this video. Please like, share, and subscribe to my channel.